Okay, it's 3 after 12. We'll get started. Again, thank you all for joining us today for our webinar on eliminating Hep C in Michigan. My name is Tim Hudson. I'm a behavioral health consultant for the Michigan Opioid Collaborative. I cover the northern 21 counties of Michigan. Before we get started, I'm going to give a brief overview on what we do here at the Michigan Opioid Collaborative. The Michigan Opioid Collaborative is a grant-funded program with the University of Michigan. We are funded by Blue Cross Blue Shield of Michigan and Michigan Department of Health and Human Services. At the Michigan Opioid Collaborative, we offer same-day free patient consults with an addiction physician in areas such as MAT inductions and guidance, options for chronic pain, obtaining community resources and referrals. We hold free monthly webinars, such as the one you're on right now, and case consultations around polysubstance use and treating different substance use disorders. Additionally, we host free education and trainings tailored to your office around substance use disorders, MAT or MOUDs, technical assistance with office setup, and general addiction treatment. We collaborate with Great Moms Model of Care to provide support around diagnosing and treating pregnant and perinatal patients with substance use disorders. We have a hepatologist on staff who provides education, case consultation, and a 3-part webinar series on Hep C. And we participate in a number of community events focusing on community coalitions to build connections and to increase awareness of substance use disorders, the benefits of medication for opioid use disorder, and reducing stigma. I will now introduce our presenter. Dr. Pani Paramuswamy is an associate professor of medicine at the University of Michigan and the Ann Arbor VA healthcare system and health services researcher focused on improving access to care for patients with liver disease. Her research focuses on the development of clinical and behavioral health care models to identify and address system-level barriers to viral hepatitis care within underserved and vulnerable communities. In 2020, she joined the steering committee of the Michigan Department of Health and Human Services Hepatitis C Virus Elimination Plan, which informs policy and practice to mitigate the spread of viral hepatitis. She also works with the Michigan Opioid Collaborative on outreach and training initiatives aimed at increasing hepatitis C screening and treatment by primary care providers in rural areas of the state. And I'll turn it over to Pani.
Hi guys, thanks for that nice introduction. I'm going to go ahead and share my screen. Hopefully you guys can see my slides okay. I'll put it into slide share here. All right, so it's really my pleasure to connect with all of you guys. Hopefully we have other opportunities to connect with one another. As Tim just mentioned, I'm one of the hepatologists at University of Michigan and Ann Arbor VA, and just really thrilled to be part of the Michigan Opioid Collaborative's, really efforts to integrate Hep C into the model of care. And so I'm going to be speaking on the topic of eliminating Hep C and trying to tailor this to our context within the state of Michigan. I don't have any disclosures. And I'll just start by saying that we certainly have the tools. So I think the real question is, why haven't we solved the public health problem of hepatitis C? So we do know how to prevent this infection, diagnose it, and treat it. And really, with the advancements in treatment in the last 7 years, we've made really huge strides in what we can do for patients who are already living with this infection. But we know that not everybody has been reached, and that gaps remain. And unfortunately, stigma and discrimination is real and part of why we haven't reached all of the people who need to be reached. So what I'm here to do today is to really kind of highlight what's new around testing, linking to care, treatment approaches, and talking about how we do this better in terms of the various settings we can be offering treatment, and touching on prevention at the end. And I just would really start and encourage us to really think about ending with this note of what we need to continue to do to really achieve elimination. And a lot of that has to do around advocacy. So we have all these great tools in our toolbox. So I would argue that now is not the time to be taking our foot off the gas, but rather to keep getting out there and advocating with partners and stakeholders in this arena. So I think it's helpful to put viral hepatitis into a global perspective. So the most recent estimates by the World Health Organization in 2019 actually showed that the number of people living with hepatitis C had dropped. It was previously around 71 million, and now globally it's around 58 million. That's a very different story than what we see, for example, with hepatitis B, where that number has actually increased by probably 30 to 35 million people globally. But you can see that based on like geography and global distribution of where people live, that the amount of infection really varies quite a bit. And unfortunately, what we also know is that it's helpful to put into perspective the number of new cases that we're seeing globally, how this translates into diagnosis and treatment, and into mortality, unfortunately. So globally, it's estimated that 1.5 million new hepatitis C infections are occur annually. And when we think about where the gaps are with diagnosis and treatment, it's estimated that only 21% of people living with hepatitis C have been diagnosed globally, and that 13% have been treated. And in 2019, we had 290,000 deaths due to hepatitis C infection alone. So because of the major public health issues around the prevalence of hepatitis C infection, WHO, along with a number of countries and organizations globally, here nationally, and even at the state level, have started to adopt global viral hepatitis elimination kind of strategies that are really aimed at two goals. One, to reduce the number of new chronic infections by 90% by 2030. So these were initially set back in 2015. And the second goal was to reduce deaths due to viral hepatitis infection by 65% by the year 2030. And these goals were around not just hepatitis C, but around hepatitis B, because the same argument can be made in terms of all of these great tools. With Hep B, we actually have a vaccine that's highly effective that can prevent acquisition of this virus. So in terms of where we started out in 2015, shown in red, and what progress we made in the first 2 years of implementing an elimination strategy globally, we know that a number of the areas where we still have for improvement, where our rates are still very low at baseline, have to do with this, the diagnosis and treatment stage, and as well as harm reduction and promoting harm reduction, particularly the setting of Hep C, but I would argue now Hep B, because of the number of new cases of Hep B paralleling opioid use disorder in areas. So in the United States, what we've seen over the last 10 years is an increase, unfortunately, in the number of acute viral hepatitis C cases. And the most recent estimated prevalence of Hep C in the United States is 2.4 million people. This has actually come down over the years. And I think this is not down just due to things like treatment, but unfortunately due to deaths also related to hepatitis C. So we think about where we are with the US prevalence, this rising number of acute cases, which has risen kind of the increases we've seen with opioid use disorder. We are not on track to achieve elimination by 2030, unfortunately, in the United States. And that rather there's some very, I would say, generous estimates that put us at maybe by 2037 without continued interruptions due to COVID and other reasons, including funding. But some estimates actually put us closer to 2050 in terms of being able to eliminate and achieve those two goals around reducing the number of infections as well as the mortality. Hepatitis C remains a major source of mortality. So I think I just mentioned, 2.4 million people in the United States are living with Hep C infection. Just to give a comparison, 840,000 people living in the United States have Hep B infection. We talk about cirrhosis, kind of a late bad outcome of having chronic infection with hepatitis C. We still have a lot of patients with cirrhosis due to Hep C. And when we think about liver cancer, or HCC, HCC stands for hepatocellular carcinoma, Hep C is still by far a very big contributor, the main contributor to liver cancer. When we think about what our response has been nationally and how this compares to our responses with other infectious diseases such as HIV and comparing it to Hep B, we know that over time, the total number of persons infected with Hep C infection has grown. So the prevalence has gone up. And this is like, if you're to compare it to HIV, we have a lot more million people infected with hepatitis C. And then you think about the number of people who have not yet been diagnosed. We've made really great strides with HIV, and I would say this is where we want to go with having less than 10% of undiagnosed infection with HIV, but unfortunately with Hep C, we have over 50% of people not yet diagnosed. So we're still thinking about kind of critical first steps of identifying people living with this problem. More than half of people living in the United States, it's estimated, have not yet been diagnosed. And you can see the contributions related to mortality are quite different between Hep C now and where we've gone with advancements with antiviral therapy with HIV. And unfortunately, there's still this very disproportionate funding when we talk about NIH funding. And what you have below is a table of the CDC's budget for the fiscal year 2022 and how this breaks out into funding for programs and services that support elimination efforts along with other efforts to combat what we're seeing with Hep C. And what we know is also that the CDC needs at least $134 million in this next fiscal year to strengthen public health infrastructure to deal with Hep C, and that the infectious diseases and opioid epidemic program needs at least $120 million to fully treat opioid-related infectious diseases, which includes Hep C. So there's been a lot of advocacy by national groups, as well as at the state and community level, trying to advocate for increased funding, but I would say we're still not there yet, and we still need a lot more funding to get where we want to go with funding programs and services. And like many things during COVID, certainly what we've seen in terms of diagnosis linked to care and treatment with COVID has interrupted things with viral hepatitis. And I think some of the challenges preventing return to normal pre-COVID services, and I think this was a survey that was done globally, include things like we've seen, I'm sure on the local level here, loss of space, lack of PPE to be able to continue to provide screening and link to care services, for example, limitations with staffing, loss of funding, transportation disruptions. There have also been some benefits, though, that have resulted from infrastructure and practice changes due to COVID. And this has included things like increasing the capacity of laboratory testing, thinking about how we piggyback more testing into one another, improving health worker training, being able to do some of this virtually, if not in person, increasing the use of telehealth, which has actually expanded some opportunities for patients to access care. And then increasing the number of medications we're giving at a time. And certainly, I know we've seen this in the opioid use disorder treatment space, but have also made us rethink how we monitor patients who are engaging on Hep C treatment, for example. So the WHO has laid out practices or principles for simplified Hep C service delivery. So now that we've made such great advances and having great tests and being able to do treatment in different settings and not requiring specialists to be involved in Hep C treatment, there's been a lot of attention on how do we simplify what we're recommending for providers to do. What is the minimum amount that we think we need to be done? Because I think for a long time, when treatment was more complicated, we were doing a lot more things to try to support patients and providers. And I think we can now make the argument that we can be simplifying things around Hep C treatment. So this concepts of decentralizing testing and treatment and integration of hepatitis testing, care, and treatment resonate globally, but I think are kind of where I've had a particular interest to focus efforts. And certainly community engagement and peer support is very important. And in a lot of treatment settings, still thinking about how we make treatments accessible, affordable, how do we make diagnostics accessible and affordable remain challenges. And I'll talk about how that context has changed somewhat here in Michigan with the elimination plan. So there are a number of evidence-based, interventions around testing linked to care and treatment. There was a nice summary that was just published earlier this year in the Lancet Gastro and Hep that just basically now tell us that we have a lot of evidence through a number of, models of care that have been studied and disseminated and published that look at point of care testing and how Hep C point of care testing, reflex RNA testing. And that is what's recommended, even though it's still not widespread and done throughout Michigan lab services in our state. Opt-out testing, so thinking about where people access services and offering it out the bat, in terms of like people who come in for emergency room visits, giving patient reminders, providing patient education. This thing called dry blood spot testing is now being used for Hep C in various kind of limited settings. And in the link to care space, certainly patient navigation and care coordination programs have shown a lot of promise. And then in treatment, thinking about how we better integrate Hep C care into other models of care where patients are intersecting or already engaged in care. All right. So what we do know is that the number of people who have initiated Hep C treatment in the United States has declined between the period of 2015 to 2020. And that this is data that's available on the CDC website, but you can see in this last year, basically since heading into COVID and throughout 2020, we've seen a decline. And on the CDC website, they say that this is likely related to COVID-19 related disruptions in terms of the number of people who are initiating Hep C treatment, along with other disruptions in testing, as a critical first step. So the National Academy of Sciences and Medicine estimates that at least 260,000 people with Hep C should be treated annually if we were to achieve Hep C elimination by 2030. And this kind of gives you the breakout. It's actually closer to like around 120,000 people a year going back over the last 5 years or so. So I think we're still getting a lot of people treated, but in order to really achieve those elimination efforts, we actually have to be doing a lot more treatment with direct-acting antivirals or DAAs. What we've seen over the years is that the HHS has started to map out elimination projects at the state level throughout the United States. So this is the most updated map as of January of this year. Michigan was actually one of the notable new additions to this map because of the elimination plan being launched in April of 2021. So let's try to put this now into like a little bit more of a context that I think is relevant for us and what's happening here in Michigan. So this is data that's put out annually by the Michigan Department of Health and Human Services. The viral hepatitis unit actually puts out a surveillance report, as many of you are aware, on viral hepatitis C, viral hepatitis B, and liver cancer. So this is data taken from those reports, looking at hepatitis C, and this is looking on the left by chronic Hep C rate by county. And on the right, what you see is the data from 2020 in just specifically adults under the age of 40. So what's happening to younger people and Hep C infection, and where are we seeing these infections? And so I think what you can see kind of highlighted here in terms of the chronic overall infection on the left and in young people is that we've seen certainly an increase in the number of chronic infection in people in the Upper Peninsula, upper parts of the state, and we're still seeing, some in the southeast corner, as well as the thumb there too. So good to know what the geography and how that relates to Hep C infection is to understand where we need to scale up services if it's around prevention, harm reduction, testing, and treatment. So it's now recommended as of March 2020 that Hep C screenings offered for all adults at least once in their lifetime, but more frequently if there's additional risk going on. And this was really a shift in how we were recommending people to be offered and to be accepting testing. Previous to this, it was very much risk-based. And the problem with risk-based strategies was that we weren't doing a really good job of assessing risk. and patients also did not always feel comfortable disclosing risk. So I think that strategy left out even more people. So there's been a lot of thought about how do we make this big push to identify all of that undiagnosed infection. I just mentioned over 50% in the United States. So it's now offered one time, at least for every adult above the age of 18. The only exception is in the setting where prevalence of Hep C infection is less than 0.1%. It's also recommended for pregnant women during each pregnancy to get tested for Hep C, and that all persons with risk factors such as injection drug use should be tested for Hep C with periodic testing. And this is where different societies, the recommendations are different and vary anywhere from 6 to every 12 months if there's ongoing injection drug use, for example. And any person who requests Hep C testing should receive it. So that's an important part of this recommendation, to say it's not okay to just test, but we have a duty to also get people linked and transitioned into care around hepatitis B. And this now has a USPSTF grade recommendation, which I know is important for reimbursement and adoption kind of more widely in frontline practices, primary care practices. So in April of 2021, our State Department of Health launched our viral hepatitis C elimination plan. And what this did was it effectively removed the whole prior authorization and along with all of the restrictions essentially around who we could offer Hep C treatment to. And I'll tell you how Michigan differs from a number of other states in a minute. But so there's no longer a prior authorization for their preferred pangenotypic Hep C treatment, glyceprevir probenecvir, otherwise known as Mavyret. So they actually had, Michigan Medicaid had the companies, pharma companies compete for a pangenotypic regimen to come onto formulary, and they selected this regimen. You can still get patients treated with the other pangenotypic regimens, but that does require a prior authorization approval process. And along with launching this plan, as I just said, not just eliminated the prior authorization form, but actually effectively removed all of the other prescribing restrictions. So the other prescribing restrictions included having to include the name of a Hep C specialist on your prior authorization. That's no longer there. There are no sobriety and drug use restrictions around treatment, which is important given all the models of care, particularly for patients engaged in treatment around alcohol use disorder, opioid use disorder, showing that treatment can be very effectively and safely done. Michigan is, I would say, become the outlier now. There's still a number of states that have a number of restrictions, and the restrictions that I just mentioned can be around who's allowed to prescribe this. So in some states, you have to be a Hep C specialist or do this in consultation, as we were still doing up before April 2021 here. A number of states still have, this is as of 2022, and this is based on the Medicaid plans at the states. 34 states have eliminated or reduced fibrosis restrictions. So when these treatments first became approved, they actually, most states actually had restrictions around having to have very advanced or at least middle of the road fibrosis, when the whole point of treatment is to prevent these bad outcomes from happening. But so that's improved over time. 30 states have loosened sobriety restrictions, but 22 still remain. And 28 states have scaled back now prescriber restrictions, but 15 states still require you to be discussing the cases with a Hep C consultant if you're not a Hep C or infectious disease or hepatologist prescribing. So Michigan is now one of a few states that have removed all the prior authorizations. So 41 states still require prior authorization forms, which is tedious, it's onerous, it captures all of the various restrictions enforced by the state payers. And Louisiana and Washington were the first states to remove the prior authorization in 2019, and Michigan most recently removed ours in April of 2021. So the National Viral Hepatitis Roundtable, along with the Center for Health Law and Policy Innovation at Harvard, now tracks and gives state Medicaid programs a letter grading based on prescriber restrictions. And Michigan now has an A+ rating, most recently earlier this year. because we've removed all of our prescribing restrictions. But you can see how this is very different than a number of states, and some of the restrictions are still somewhat nuanced, dependent on, individual payers under Medicaid and what will allow for in terms of restrictions. So I just will start by saying that, certainly a critical first step to eliminating Hep C is just knowing who has it, right, at this point. So I will also talk about prevention, which I would also argue is a very important, critical part of elimination efforts, but we still have far too many people living with this infection who we just haven't yet diagnosed. So testing still remains a critical first step. And it starts with an antibody test. And if positive, patients need to have a virus level or Hep C RNA PCR drawn. And what is recommended as best practice now is for Hep C antibody test to be coupled with reflex testing. So when we think about all the steps we put a patient through, and even a provider to walk a patient through, and a system to walk a patient through, the more steps we create, the more fall-off there is in between steps. And reflex RNA testing also enables you not to just say you've screened positive, but in that first stage of communicating results to a patient, to say you not only are tested positive for the antibody, but you really have infection. You didn't clear it, and if you were previously treated, you weren't cured. To really communicate to a patient what their status is around this. That the antibody alone just tells you if you've ever been infected, your antibody stays positive lifelong after you've been cured. So it's not a good reflection of what's actually happening with the patient right now. And 15%, remember, people who acquire this infection will go on to spontaneously clear it. So it's not the majority, it's a very small percentage of patients, but you want to be able to tell somebody that you not only have been exposed, but do you still have it? I think that's the thing that we really want to engage patients around. This reflex RNA testing can be done with one blood draw and collecting them, but they're done in different tubes, which is, I think, the major sticking point for why it hasn't been widely adopted, even in laboratory programs across our state. I've actually raised this as a kind of question to our counterparts at the State Department of Health about what efforts are we taking around trying to get this more widely adopted, since there's so much variation. And there are a number of efforts that are currently being undertaken at the state level. Some of it is streamlining communication platforms to all the laboratories, creating a directory, surveying which labs are not doing reflex RNA testing to walk them through a process to adopt this. So I think this is still an area where we need to see a lot of improvement. Most of the local labs of providers we're working with and in the various counties do not have reflex RNA testing, but this is a best practice we should be moving our health systems towards, and has a lot of strength of evidence around it. So when we think about Medicaid beneficiaries and Hep C testing by month, what you can see here is that there's been, somewhat of a variation. What you see in pink here is when the COVID-19 started and how that led to obviously a drop in testing services. And then in April of 2021, we had the launch of the elimination plan. And what you see is that testing, for a large part, has gone up since COVID started, but it hasn't like skyrocketed or anything since the elimination plan, let me say it that way, has been released. We do want to encourage more and more providers to be doing testing in their practices, again, for at least all adults one time, but thinking about if you're engaging with patients that have ongoing risk, to think about additional testing, including pregnant women and those with ongoing injection drug use. So testing is still a critical first step, and we need to be doing more of it and thinking about how we do more of it in different settings. But the next step after that is getting people into care to talk about treatment. And every person living with Hep C should be evaluated in terms of being a treatment candidate for Hep C. Direct-acting antiviral therapy is approved down to the age of 3 years of age now. So I'm obviously not going to cover the pediatric patients, but it is good to know that that therapy is now approved in the United States, not yet globally, but in the United States it has been approved. And DA therapy has not yet been approved for women in pregnancy, and I think this still remains a major gap. CDC, AASLD, ACOG recommend testing with each pregnancy, as I just mentioned. Hep C infection is a biomarker. A lot have argued for opioid use disorder. So this should be also thought of as an opportunity to engage pregnant women around opioid use disorder and treatment for opioid use disorder to prevent harms to moms and the fetuses. There has been one phase 1 study that evaluated the safety and efficacy of one DA regimen, which was ladipasvir and sofosbuvir during the 3rd trimester. They treated 10 patients. All 10 patients cleared the virus and were cured of hepatitis C, and there was no transmission to the baby. That's a very early study. We've been eagerly waiting for additional trials and data to be done so that we can hopefully have this as a potential treatment option, but it's still an area of study. There's inadequate safety data for the use of direct-acting antivirals in breastfeeding. And treatment, so in pregnancy, still remains a strategy that we need more data on. So thinking again, how you move a patient once they're tested to the next phase of being evaluated for treatment. So what I've shown here on the figure on the right is once you know you have a patient with Hep C, a basic workup for their Hep C includes additional laboratory, finding out when the first time they were diagnosed. Chronic infection is defined as having this infection for at least 6 months. Sometimes you might have patients, none of our tests tell us when a patient has had it, right, or how long they've had it. So a lot of that is by history to try to make a determination, has this patient had it for some period of time and therefore not likely to spontaneously clear this, right, if they're in an acute phase versus chronic, and therefore be considered for treatment. And then I would say in a very important part of moving a patient towards thinking about treatment is assessing their fibrosis status. And this can be done non-invasively. So assessing whether or not a patient has very advanced liver disease or what we call cirrhosis can be done with non-invasive scores that just use the patient's age, AST, ALT, and platelets, for example, the FIB4, along with other proprietary tests that are available through laboratory tests. Once you determine whether or not a person has advanced liver disease or not, then you can also assess for drug-drug interactions. So looking at other medications that the patient might be taking and whether or not there would be any safety concerns. We try as much as possible not to interrupt other medications with introducing direct-acting antiviral therapies, but selection of therapies can also help circumvent, often drug-drug interaction issues. The 2 band genotypic regimens that you'll see most commonly used are the glucepivir, probenecvir, 3 tabs daily, which is given with food for at least 8 weeks or up to 12 weeks, depending on the treatment history, or sofosbuvir, velpatasvir, 1 tab daily with or without food for 12 weeks are the typical regimens you'll see. And again, the goal of treatment is to cure a patient of their virus, of what we call sustained virological response. So you treat the patient for 8 to 12 weeks of direct-acting antiviral that they take daily, and then you monitor them for 3 months off of treatment to see if virus stays undetectable. And that, if it does stay undetectable at 12 weeks or 3 months after the end of treatment, then that person has achieved a cure, or what we call a sustained virological response 12. And we know that the cure is associated with reduction in liver inflammation, reduction in fibrosis in some patients, and improvement in portal hypertension. So even in patients with very advanced liver disease, it can help melt away significant fibrosis and reduce bad complications related to cirrhosis and portal hypertension. And now some early studies showing a reduction in mortality for those patients with more advanced liver disease. When we think about testing and link to care and thinking about where we can be scaling up these strategies or integrating these strategies, I think thinking about the harm reduction settings and where we have room for, possibly growth or improvement, and thinking about how we do that as reflex RNA testing, right? Working with the local lab partners. So this is just data that I grabbed from the Michigan Syringe Service Program report that was includes data up until December of 2021. You can see that the number of participants that are accessing these services, as well as indirect contacts, so people that they might be sharing some of these syringes with, or distributing them to in their social networks. and then the total number of syringes distributed. And I always think about this in terms of, again, where can we be piggybacking other testing services into harm reduction? And, one thing that I always like to look at is how much HIV testing are we doing, and where are we doing this? And also around Hep C, and thinking about how we can scale up this effort. So again, thinking about where high risk individuals are already engaged in care and bringing services to them, to places that they trust, feel less stigmatized, and are already accessing services. So
Honey?
thinking about, yeah.
Hi, I'm sorry. The slides don't appear to be changing. The slide that we're still seeing is the Medicaid HCV access slide.
Okay, sorry about that. Give me 1 second. I'm going to go back. Thanks for pointing that out. Can you see this slide?
Yeah, this one's showing the testing and link to care and harm reduction
Okay.
settings.
Okay, I'm sorry about that. So you probably missed a few of these slides. Okay, I won't go back through them. Maybe at the end I can kind of like end on one or two of them. But this was the slide I was just talking about that showed what Michigan Syringe Service Program report data looks like through December of 2021, and testing for HIV and Hep C. So thinking about, again, where can we co-locate or integrate Hep C services, particularly on the testing level, but then also having appropriate linkage to care strategies, and thinking about how we support providers working in these settings to build their capacity to do more Hep C testing and treatment. My slide's advancing here, Tim. Okay. All right, so this looks at Medicaid beneficiaries that have started Hep C treatment over the last 3 years between 2018 and 2021. And what you can see is, again, the pink area here is when COVID kind of interrupted things, and when our elimination plan was launched in April of 2021. So I think we still want to continue to see the numbers increase, given the number of people still not yet treated in the state of Michigan. And then when we think about the cumulative total of patients prescribed and Medicaid beneficiaries over this 3-year period, you can see that there has been overall growth over the years between 2018 and where we are in December of 2021. One good resource for all of you guys to be aware of is that the Michigan Department of Health and Human Services has now also created a Hep C provider directory or map of services, if you will. So this is a great way to think about if your capacity particularly is only testing and you're looking for a way to connect patients who test positive or come to you telling you that they know that they have this infection. And if your capacity isn't yet to treat them, think about using this as a resource to try to get them connected in with a provider, depending on where you are, where they are. We've had a lot of discussions about patients getting tested, for example, in residential treatment settings, and then not getting the Hep C addressed while they're in the residential treatment program because they might be there for another reason that is the primary focus. So then once they're out of the residential treatment program, how do we do a better job of getting people connected to care? I would also argue that we should be thinking about offering Hep C treatment if we can build that capacity in all those different settings so that we can treat the patients where they're at and offer them offer this treatment when they're very engaged also in health services. The Michigan Opioid Collaborative program, as Tim started out by saying, added Hep C services in October of 2020. And what I usually do is we just set up a one-on-one meeting with anybody who's interested to find out how we can support you. This is really trying to think about what your needs are and how we can leverage support on our end to help you grow your capacity. Some of it starts with just discussing what testing looks like. Is there reflex RNA testing? Do you want us to be involved in discussions with your lab around reflex RNA testing? But the bulk of the services really have to do around direct case review. Most of the providers who've engaged with us have never done Hep C treatment before meeting with us. And so they're really interested to learn so that they can bring that treatment to their patients. The providers we work with have included family practices, federally qualified health center, primary care providers, addiction providers. So really thinking about frontline providers that are already caring for patients, large part who have opioid use disorder, and Hep C is an infectious disease related complication. So we will walk through with providers how to approach Hep C. We actually have a one-page form that walks you through what labs to order, and then we review those cases. You can directly email those cases to me, and then I usually respond within 24 to 48 hours with my recommendations to just try to enter into a discussion about how I would approach this patient. There's no PHI that's exchanged, so this is really thinking about how do we leverage case-based learning to grow provider capacity. Every other Friday, we have a bi-weekly case conferencing session that's open to anybody who wants to join. It's not required, it's not mandatory. There's no paperwork or requirements. It's really meant to be a space where providers can come together across the state and discuss cases. I've done a lot of learning from a lot of the providers around complex substance use disorder management, and have been discussing how we bring Hep C treatment into individual kind of cases we're discussing. And then there is, as Tim mentioned, a 3-part webinar that's taped that goes into more details around treatment, fibrosis assessment. I think our talk today is really meant to give you kind of like a flavor around how we think about approaching these things, but they're more detailed webinars that are self-paced. You can access them anytime. Basically what's in the webinars is what I also go through with an individual provider, figure out how we can better support and address your needs. This is like data from the first 46 cases that we reviewed in the first year of the program. We actually did more than 46 cases, but these were the first 46. So you'll see 3 of the providers we started working with were in the Upper Peninsula. 2, well, the rest of the providers were mostly in the northern kind of tip of the mitt, or the upper east side of the state, if you will, eastern corner, and some providers kind of more locally in this southeast area. But I think one of the barriers that still has presented a challenge to getting people initiated and also to avoid interruptions in treatment has been justice involvement of our persons living with Hep C. That has impeded or led to disruptions in care or delay in initiation of treatment. But of the 46 cases, 80% actually started treatment. And then we asked the providers just to share back, how many of them actually got cured. And over 50% were cured, but there were a number of people who weren't. And we, looked into like reasons why they weren't cured. There were some lost to follow-up, justice involvement. Some were still pending their cure labs. They hadn't come up on the 12 weeks, if you will, of being able to determine a cure. So we also have a university-based pharmacist that if we need to check drug-drug interactions more formally or discuss whether or not we need to lower a dose of another medication or a different Hep C treatment strategy, who gets involved as needed in cases. And I think what we've been really surprised to learn from the providers we're working with is that they've actually now started treating, after discussing a few cases with us, they grow a lot of comfort around doing Hep C treatment on their own. And they've now, at least 3 of the providers have started to train other local providers who are now doing Hep C treatment. So you guys are engaging through this program, and then also kind of building a network of Hep C support and treatment in your communities, which I think is just so awesome. I think some of the successes in terms of Hep C treatment nationally, certainly like VHA, where I also practice at the Ann Arbor VA, has done a remarkable job to treat our veterans living with hepatitis C. So in 2015 to 2017, Congress appropriated $3 billion towards Hep C elimination efforts within the VHA. So during this period, they actually ramped up Hep C treatment so that 2,000 veterans a week were being treated. And by March of 2019, 116,000 veterans had initiated DAA treatment with cure rates over 90%. But this was really due to a number of implementation strategies. That was a multi-pronged initiative to say we want to get to every veteran and get as many of them treated and cured as we can. Another study that's helpful to be aware of is that there's, you'll hear about this, I think, more and more, an approach to minimal monitoring in patients with Hep C. So this was a nice study that was finally published in April of this year, just a couple of months ago. It was an open label, international, pragmatic study that looked at 400 patients living with Hep C, and all of the patients were giving sofosbuvir or velpatasvir, but the difference here was that there was no pre-treatment genotype testing, no scheduling for treatment visits or labs. Patients were dispensed all 84 tablets, all 12 weeks of treatment on entry into the study. They got one remote telephone contact by a community health worker at week 4 and at week 22 to make sure that they would come in for their cure labs. 95% achieved an SVR, only 5% were non-responders. And I think the safety profile is there, looked pretty good in terms of minimal adverse events. And so it really raises this question of how much monitoring is needed on Hep C treatment. And I think this paradigm is going to be shifting in the years to come in terms of thinking about, again, how do we adopt harm reduction principles to make this low barrier, low threshold care in terms of what we're talking about for the Hep C piece of it. And I think I mentioned this at the beginning, there's one new thing that's coming out with Hep C in pregnant women. There's a international pregnancy registry that's being launched to try to help collect data around safety of Hep C treatment. So this is like going to be global data, but it will help inform, I think, local practices potentially. There was one really nice study that was published last year it was a quality improvement study looking at Hep C evaluation in pregnancy, and basically teeing up pregnant women to do all the pre-treatment evaluation for Hep C in the 3rd trimester of pregnancy, so that immediately postpartum, if they weren't breastfeeding, they were offered treatment for Hep C. And what they were able to show was that in women who wanted these were I would say superstar OBGYN teams, because they learned not only opioid use disorder treatment, but they learned Hep C treatment. So they really expanded and grew their capacity for both of those things, but they offered all of the women they were caring for postpartum to initiate on Hep C treatment. And they were able to show a lot of women started treatment, but they had a lot of problems with loss to follow-up. And so you can see the SVR12 rates were pretty low. And so I think their conclusion from this is that we still need treatment in pregnancy as an important strategy studied. And then prevention. So this is just, again, data globally from WHO to show you percentage of harm reduction programs and how this breaks out. So I think there's still a lot of room for improvement in needle and syringe programs, as well as opioid use disorder treatment programs. And one slide about vaccines, because this is a common question. I think the question still remains, when are we going to get there? We're not there yet. There's been a lot of challenges with conducting clinical trials in this area. It's been a low funding priority. It involves recruitment of underserved, marginalized group, which a lot of researchers are not focused in. And it's a genetically highly diverse virus, which makes development of the vaccine more challenging. And are looking at developing an mRNA vaccine and whether or not this could help, like it did with COVID, open doors for vaccine strategies. I'll just end by saying that I've spent a lot of my time over the years thinking about how we rethink the role of specialists in supporting Hep C elimination efforts, thinking about how we move from being in the front of the line to treating most of the Hep C to supportive. And so how do we leverage our expertise and tools to support you, and think about how we can help fill training gaps, and thinking about how we can make this low barrier, low threshold care. Hep C is one piece to a larger, more complex picture in opioid use disorder. And I think advocacy still remains a really important piece of what we're doing. I'll just end by saying, we can cure Hep C, but we can't cure it unless we find it first. And that Hep C screening with reflex RNA is the best way to do our testing. All persons living with Hep C should be assessed for treatment candidacy. We can support your Hep C treatment needs, so reach out if you want us to help. And I think together, eventually, we will achieve elimination.
Thank you, Pani. All right, I'll open up to the audience. If anybody has any questions, please feel free to unmute and ask, or if you're more comfortable post your question in the chat. We've got about 7 minutes roughly, so we'll leave it open for the rest of the time for any questions. There was a question submitted during registration that asks, in primary care settings, what labs are needed?
I think I missed the first part of your question, Tim, because I had a pause on my internet connection. Sorry about that. So if for testing or for actual moving to treatment?
It says, I don't know if this provider's on that maybe can provide some additional context with what they're looking for. But the question says, treating Hep C in primary care settings, what labs are needed?
Yeah, so I think I had it on one of those slides, but it typically would just be a CBC, a Hep C viral load, right? Because you're going to need to establish, obviously, that they have, which you would have had usually at that point, right, through your testing strategy. A liver panel, or a comprehensive metabolic panel. That's so that you can have the AST, the ALT, but you also want to make sure that the GFR looks normal. These treatments are safe up to like a GFR less than 30, and then have some caution. Liver enzyme tests are helpful to be able to calculate a fibrosis assessment, a FIB4. We typically recommend 2 fibrosis assessments. So the FIB4 can just be done using your AST, ALT, platelets, and age. It's a calculator online. And I think I go into this in a little bit more detail in the webinars, so feel free to check those out. But a lot of sites also do a second test, which can be another serum proprietary, like a fibro test. You'll see that on some of your lab panels. So just basically a comprehensive metabolic, a CBC, a Hep C viral load. Now, the other good practices is to check their Hep A and B status. You want to know that for opportunities for prevention. We still have a lot of acute cases of Hep A and Hep B that are happening throughout the state, and we have opportunities to prevent that. People with Hep C, if they also get acute Hep A and B, are not as likely to do as well, because they already have one problem going on in their liver. And the other reason to know your Hep B status is that there's a small risk of reactivation of Hep B with Hep C treatment. So knowing the status up front usually doesn't deter us from proceeding with treatment, but it's a good practice to check for both of those things along with HIV. I'm happy to make these slides available for anybody who wants them after. I can send them to you guys, Tim, to send to the group if they're interested. And what is the role of fibrosis testing with a negative for fatty liver disease, with negative hepatitis screen? So a fibrosis assessment is still important. What we're trying to essentially determine is somebody progressing, developing a bad outcome of fibrosis, because not everybody develops that, especially with fatty liver disease. But you also want to know with that fibrosis assessment, is this somebody who already has cirrhosis? Because despite what you do for the Hep C or the fatty liver, or whatever the liver disease is, there's additional management that's recommended for somebody who's got cirrhosis even after we cure them of their Hep C. They're still at risk for liver cancer screening, so it's recommended they get ultrasounds every 6 months to screen them for liver cancer. And liver cancer can happen 8 to 10 years out after you're cured of your hepatitis C. And it's also recommended as a quality metric to screen them for varices. So the fibrosis assessment is very important. And you can still treat compensated cirrhotics with Hep C. In frontline practices, it's recommended for patients with decompensated cirrhosis to be treated in a liver transplant setting to see if liver transplantation is an option or needed. And it's also recommended that MAVRIT not be given for patients with decompensated liver disease because of the risk of additional liver injury. So knowing whether or not a person has cirrhosis is a very important thing for a lot of different reasons. I'm just looking at the questions in the chat here, Tim.
Yeah, there's one that says, I provide STI testing, including Hep C screening in the county jail. It is outside my scope of practice to provide treatment, but would love to be able to better refer clients for treatment when they are released from custody. The jail setting has traditionally not been a viable place for treatment because it's uncertain how long clients will be in custody.
Right.
Providers are hesitant to start treatment when clients may not be able to complete treatment and monitoring. The question is, how do you recommend or suggest I go about referring clients that are in custody to providers who can treat them upon their release? I think one
Yeah.
thing for sure, as we could always, your local behavioral health consultant could help you coordinate that by identifying a local provider. But Connie, I don't know if you have some other thoughts on it as well.
Yeah, I think this is where more and more we should think about also, one, I think that's a great suggestion, Tim. I think we are happy to be helpful in trying to connect patients. But I would also take a look at that provider directory that we're now developing and updating constantly. It's not necessarily going to fill everybody's need, right? Because there's still some gaps in terms of where providers are located. So I do still think we're hoping more providers are interested to learn Hep C treatment so we can expand that directory. But definitely think about that as a way to find a provider to refer. And I would just say that there are now some treatment models looking at doing this in jail settings. The big challenge, as you rightly point out, Heather, is not knowing how long a person is going to be in the justice system in that setting. And so there's a lot of hesitancy. It also feels like a missed opportunity, obviously, but it also then hinges on having some capacity to be able to do it in that setting. In New York, where I was before I moved back home to Michigan a couple of years ago, they were doing it in the jail settings, and they were developing models where patients who started were given, for example, the rest of their bottle of pills on exit, and then scheduled to see a provider because of the time issues around activating insurance and other things. So Matthew Akiyama in New York City has published a little bit on this model, and I'm hoping to see it leveraged kind of more broadly at some point in the future. It would be great.
We see similar difficulties with patients who have a substance use disorder, who are inmates in the jail, they're receiving treatment, but then how do we can make that connection once they're out of jail as well? All right. So looking at our time, it is 1 o'clock. So I want to be respectful of everybody's time, and we'll wrap up now. Again, in the coming days, your local behavioral health consultant from Michigan Opioid Collaborative will reach out to you and provide the link for the credits, which have to be completed within the next 48 hours. So by 4 p.m. on Friday, they'll also include information on these slides as well. Thank you all for being here, and we look forward to seeing you next time. Thank you, everyone.